Hello again, and thank you for joining us. I'm Rahul Gosain, here with my brother and co-host, Rohit Gosain, on our podcast, The Oncology Brothers. As community oncologists, our days are filled with a mix of solid tumors and hematologic malignancies. And CLL is one that we encounter often. It's the most common leukemia in adults, and the landscape has evolved dramatically with BTK and BCL inhibitors.
Absolutely, Rahul. We are excited to continue to bridge this important gap between community and academia. And today, we are thrilled to have Dr. Mazyar Shadman, a professor of medicine, focusing on lymphoid malignancies at the Fred Hutch Cancer Center at the University of Washington. Mazyar, thanks so much for being here today.
Thanks for having me.
Mazyar, let's start with the basics. Not every newly diagnosed CLL patient needs treatment right away. Some can be observed, especially if they're asymptomatic with slow lymphocyte doubling time, even if they have high-risk features like TP53 or 17p deletion. But when treatment is indicated, say due to symptoms, rapid doubling time, or cytopenias, what's your essential workup upfront? Scans, bone marrow biopsy, cytogenetics, flow cytometry. What does it look like before you commit to any treatment?
Great point. I'm glad you brought up the point that not everybody needs treatment, and that's irrespective of even having high-risk feature. I wanted to mention there's a study by SWOG group, the EVOLVE trial, that is targeting patients with high-risk disease to see if early intervention would improve overall survival. Until we have the results of that study, the practice is to wait for the patient to meet the IWCLL criteria for needing treatment. Once they do, we absolutely need to have a number of tests done or repeated. FISH is important. In the era of novel agents, the one that we care most about is del17p, that's deletion in the p53 gene. The FISH study will give us additional information, including 11q and some other ones, and information about the p53 gene mutation, because there are patients who may not have the deletion, but we may find the mutation in the p53 gene. Of course, the conventional karyotype to see if patients have what we call complex karyotype, and then the IGHV mutational status. Now, the IGHV is a test that does not change over time. If you have IGHV status checked once at the time of diagnosis, that is also true for later lines of therapy. We don't need to repeat it. FISH, molecular profiling of the CLL cells and the IGHV mutational status from the disease standpoint. Of course, we need a comprehensive history to understand the comorbidities. Ones that we probably care most about are cardiovascular risks and comorbidities, and also bleeding disorders. These two are specifically relevant in picking the right treatment. Then we need to understand more about the patient, basically social and support status. Some of these treatments require multiple clinic visits, and we need to have a good understanding. If someone lives 2 hours away and they don't have the means of being in clinic weekly for 8 weeks, certain treatments that we will discuss shortly are not relevant.
Absolutely.
And that can all be obtained mainly on peripheral blood itself. Does one need PET-CT to evaluate this nodal status, and also any role of bone marrow biopsy?
So PET scan is something we use if there's any question about potential transformation of disease to high-grade lymphoma. Right. If there's any clinical suspicion for Richter's transformation, PET scan is extremely helpful in guiding us to biopsy the right spot.
Yeah.
Otherwise, before starting treatment, a CT scan would give us a baseline that we need. Bone marrow biopsy is only needed if there is a clinical reason beyond the CLL diagnosis. So if I have someone who has CLL and now they're showing lymphadenopathy and was clearly CLL progressing, I don't do bone marrow biopsies. But let's say you have somebody with isolated thrombocytopenia. The question is this CLL that needs treatment, or is this an ITP or immune thrombocytopenia that they can treat? Many of these patients have prior history of other conditions. We always think about alternative causes for cytopenia. In that case, bone marrow biopsy would be relevant, but not as a routine test.
Now, once we have a staging workup, flow, and cytogenetic, next step is talking about the treatment options that are available. Mazyar, if you could walk us through your treatment algorithm in terms of time-limited approach versus continuous BTK inhibitors, any role of adding anti-CD20 to the BTK inhibitors, and how do you pick BTK inhibitors when multiple of them are available? There's quite a bit to unpack here, sir. If you could walk us through your thought process in making this treatment decision.
when talking about the standard of care treatments, there's one main question that I start asking the patient. These treatments are great in terms of efficacy, and we don't know which one is better. That is kind of good because then we don't have to kind of, at least at the moment, and there are studies that are looking at these strategies in a head-to-head comparison. Right now, we know these treatments are effective and disease will be controlled for the duration of follow-up that we have. They're all producing long remissions. So with that, I focus a lot on patient preferences in terms of time-limited versus indefinite therapy. I start by asking, are you interested in being able to stop treatment at some point in the next 12 to 18 months? If the answer is yes, the follow-up question by patient is like, why do you even ask? If I have the option of stopping versus not, why would I continue? And then I explain that you need to do some more work up front. So these two questions are hand to hand. So if somebody's absolutely interested in stopping treatment, and if they're willing to accept that initial work, then that's the way to go. And this includes patients who, let's say, they're very active, traveling for work, or have a very busy schedule. There's no way for them to come to my clinic on a weekly basis for 8 weeks. And they're okay with taking a medication that does not bother them for a side effect profile. And then you go with indefinite therapy. In my practice, most patients like the time-limited therapy. I realize that in community, that ratio is reversed, which is interesting. So if they go with time-limited, the FDA-approved option is venetoclax and obinutuzumab per CLL14 study. In near future, we may have the combination of Acalabrutinib and venetoclax based on Amplify, but at the moment, we don't have that. I start talking about the logistics of starting with the CD20 antibody and going with venetoclax after that and stopping at the end. I do check for MRD at the end. I routinely don't act on it, meaning that even if they're positive or have detectable MRD, I don't think we have strong evidence to suggest that continuing beyond that endpoint would benefit the patient. There are patients who feel more comfortable doing that. If I have patients with high-risk features, meaning if they have p53 deletion or mutation and they decided to go with a time-limited approach, and they're MRD positive at the end of the treatment, and that would be reasonable to continue venetoclax. But the standard is to stop no matter what, and just knowing that duration of remission is shorter in patients who have detectable disease at the end of defined treatment period. Now, that's kind of our time-limited approach, and it's not preferred for patients with p53 mutation or deletion. I make sure that they understand that if they take that approach, it's not wrong, and many patients do it. They just need to understand that if their main goal is to have the longest remission, then continuous BTK inhibitor is the way to go. And, so those patients, or even some patients without abnormal p53, decide to go with a BTK inhibitor because they, as I said, they don't mind taking a BTK inhibitor for a long duration. The second generation BTK inhibitors are extremely well tolerated. Many patients do well without calling us a lot, which is great. So now getting to your question of if somebody decides to go with a BTK inhibitor, we have 3 of them, at least for covalent ones, and the non-covalent BTK inhibitor, Pirtobrutinib. First of all, in the first-line setting, we used the covalent BTK inhibitors. That's where the approvals are, although there was a press release recently of Pirto versus Ibrutinib in a study that did include patients in both lines. That study is not mature and has not led to any approval yet. So we go with the covalent BTK inhibitor. If there is access to Zanubrutinib or Acalabrutinib, I don't think there's any role for Ibrutinib these days in terms of we have in the relapse setting multiple studies showing that both Zanubrutinib and Acalabrutinib are superior to Ibrutinib for safety profile, and in case of Zanubrutinib, even for efficacy. So Acalabrutinib and Zanubrutinib both have long-term follow-up in the first-line setting. Zanubrutinib as monotherapy versus bendamustine rituximab with a PFS advantage regardless of the IGHV mutational status. And you have the same kind of data with Acalabrutinib in the Elevate-TN study. In that study, there was an arm that also included obinutuzumab, and that goes to the question of using CD20 antibody. If you look at the Elevate-TN study, there was a PFS advantage of adding obinutuzumab to Acalabrutinib, but interestingly, in patients with p53 mutation or deletion, that advantage was not observed. In my practice, I use BTK inhibitors as monotherapy For me, the only reason to add a CD20 antibodies, there's a reason like immune cytopenias. If I have to also treat some degree of ITP or hemolysis, it's a nice way of having access to those drugs. Zanu versus Acala is a very commonly asked question. I think they're both great drugs, and there's no head-to-head trials, so we should all remember that. In the relapse setting, Acala versus Ibrutinib in Elevate RR showed that these two are efficacy-wise very similar, and safety profile is in favor of Acalabrutinib. This study, Elevate RR, was done in high-risk group of del17p or 11q. The Alpine study compared Zanu versus Ibrutinib in the relapse setting, all comers, and it showed that safety profile is in favor of Zanubrutinib except for hypertension, but efficacy was in favor of Zanubrutinib, both in entire population and also predefined high-risk groups. There's that data there, and then physicians make a decision of what to use. There are some indirect comparisons between the two drugs, and in general, I would say that safety profile is comparable, and there is some signal of improved efficacy with Zanubrutinib, which makes sense given the pharmacology of the drug. That would be the choice of one of the second-generation BTK inhibitors in the first line. I think that covers our first-line treatment.
Absolutely, yeah. Rohit, you were not joking when you said there's a lot to unpack here. But this is exciting for our patients because they have better and more treatment options. But a few things to reiterate, Mazyar, that you brought up for fixed duration regimen when we're using venetoclax, even for Amplify, not approved yet with Acalabrutinib and venetoclax. This is still early. The data is limited here. But one thing to keep in mind, this is not the ideal regimen for high-risk patients with that TP53 and 17p. And then we have BTK inhibitors that continuous therapy, data to support that BTK continuous therapy in that high-risk patient is better. And then you also touched on venetoclax uptake has been low in community settings. And I think that I can defend to that a little just because of the complexity around venetoclax, the time-intensive ramp-up. And if a patient is in rural settings, for them to come back and forth ends up being cumbersome. And when we're talking through all this data, it's not as simple as saying, all right, off you go on few pills for just 1 year and then you're done versus a pill forever. A lot of this conversation ends up happening with that patient in front of us, and there are nuances to that. Mazyar, with that in mind, this takes us to the continuous BTK inhibitors. Mazyar, in picking that right BTK inhibitor, we have to keep side effects in mind. Can you briefly touch on some common side effects and clinical pearls for these available BTK inhibitors?
Absolutely. Before I get there, to your point of for high-risk patients with high-risk features and the data with BTK inhibitors in the frontline setting, Sequoia study was the study that led to the approval of Zanubrutinib in the first line and had an arm that included patients with del17p. The long-term follow-up was presented at ASCO 25 and EHA and Lugano. And we're basically seeing the efficacy of Zanubrutinib is in patients with high-risk feature is very similar to patients without high-risk features. And this is the largest prospective study looking at a monotherapy of a BTK inhibitor in del17p with 110 patients enrolled. So the efficacy is very solid with Zanubrutinib. That's the drug that has the most mature data in a single prospective trial for frontline setting of del17p. Now, in terms of side effect profile, both drugs are well tolerated. We don't have head-to-head trial. We do have studies that show that if you have patients who are on Acalabrutinib and they have adverse events because of which they have to stop the drug, the switch study published in Lancet Hematology was the first publication looking at Zanu in Ibrutinib intolerant, mainly and some Acala intolerant. And now we have the paper just actually very recently published in Blood Advances that shows patients who don't tolerate Acalabrutinib can do really well on Zanubrutinib in terms of the side effect profile, being able to drive clinical benefits from it. Acala has a unique side effect of headache that starts early after starting treatment. Most of the time it's self-limited and well controlled on over-the-counter medications, and caffeine also helps as well. In terms of Zanubrutinib, the hypertension in Alpine study, the rate was not different than Ibrutinib. So I would say hypertension in practice, we just need to be aggressive and work closely with primary physician or a cardiologist or nephrologist, whoever manages the hypertension. And most of the time, we have a pretty good control as long as we're not letting it go. I mean, multi-drug management of hypertension is critical. We did a study with 13 other sites. We looked at hypertension that was accompanied by patients taking Ibrutinib, and we showed that you need more drugs. Some classes may have a more positive impact, but I have not found hypertension be a limiting factor in my practice. But if you have a patient whose main problem is high blood pressure, they're on 4 drugs and still poorly controlled, then it is not the right drug for that patient. So other side effects, I would find them in general very comparable. The atrial fibrillation, ACE slaughter are both at a low range. These drugs as a family should be avoided in patients with major cardiac issues, and that does not include AFib. We can use BTK inhibitors safely and even have patients on DOACs. I avoid using BTK inhibitors in patients who are in dual antiplatelet therapy, like aspirin and clopidogrel at the same time. Beyond AFib, like dysrhythmias and heart failure, I get a cardio-oncologist on board to make sure they're okay. Most of the time, they clear the patient, but I wouldn't do it by myself. There was some signal of neutropenia with Zanubrutinib in head-to-head trial versus Ibrutinib that didn't translate to infections or high-grade problems. I would say in general, the 2 drugs are comparable.
And I feel like in community, we are used to managing some of these side effects and it comes off with an ease. And what you stated, Rahul and Mazyar, that it is more adaptable as opposed to venetoclax approach because just the supportive care management that is involved here. Mazyar, you briefly touched on the MRD aspect. It is rather positive when one is on venetoclax-based regimen and has completed that year of time, you will still stop the venetoclax and have that conversation with the patient. This is even more relevant when talking about the indefinite approach, where after 5 to 6 years, patients are still seeking the benefit of disease being in control, but they want to come off of it. Any role of MRD activity there, and is it even ready for prime time for community?
Well, my short answer is no. Of course, there's a lot of interest in MRD. It's a major scientific focus and part of the clinical trials. In practice, I think the goal is to relay the important messages that are practical and avoid putting more noise to that message. If somebody's on a BTK inhibitor for 6 years and they want to stop, I would just stop. I don't think that MRD helps. We have data from clinical trials. We do have patients who come to you after 3-4 years and like, hey, do I really have to stop? Do I really have to continue? I don't know if MRD checking helps. I think many of these patients, you just stop and they do well for years. Same thing with fixed duration. I think where MRD is becoming more relevant, and that may be beyond this discussion, when oral BTK inhibitor and BCL2 combos become more and more of an option, and maybe we have a different conversation later. Yeah. I think there is some data emerging that an MRD-guided approach, when you're combining a BTK inhibitor and BCL2 inhibitor, kind of makes sense, especially for high-risk patients. In Sequoia, Arm B, that was a combination of Zanubrutinib and venetoclax. And what we saw was that both high-risk patients, that's p53 deletion mutation, and standard risk, did really well in terms of having undetectable MRD of around 60%. However, patients with high-risk feature took longer time to get there. So maybe in that setting of combining a BTK inhibitor and BCL2 inhibitor, MRD guidance helps. It's not for practice. This is something I started to think. And we also saw the FLAIR data from UK group that MRD-guided Ibrutinib plus Ven has an overall survival advantage over Ibrutinib. So that's big, right? So is it ready for practice? No, but we may see a few things in the next year or two.
Sure. And over the last few minutes, can we touch on progressive or refractory disease? This is also one place where you touched on that triple regimen makes me a little nervous because you've used all your best treatment options upfront. Any role of looking for any resistant mutations here? Can you touch on your treatment options in this space?
Absolutely. So the good news, studies that used combination of BTKI and BCL2 inhibitors so far, because they're fixed duration and exposure is not indefinite, you don't see resistance mutations as something that would. But you're right, that was an initial concern, using all your good drugs up front. The time-limited approach may not be as big of a problem, but one key point is to differentiate between double refractory versus double exposed. So if somebody has progressive disease on either Ibrutinib, Acalabrutinib, then covalent BTK inhibitors are out, right? So you can't switch between the class. If somebody progresses on venetoclax or shortly after stopping venetoclax, and shortly is not well defined, but let's say a year, then your 2 major classes are out, right? So your covalent BTK inhibitors are out and your BCL2 inhibitor venetoclax is out. I think it's key to differentiate double refractory, double exposed. Now, if you have someone who started a covalent BTK inhibitor and they're progressing on it, you can go to venetoclax-based therapy.
Yes.
The approved study was Morano with rituximab. If I can, I get obinutuzumab because obinutuzumab is better than rituximab in CLL. We know that.
Yes.
We may be able to get Pirtobrutinib now. It's on the guideline, and the study showed that post covalent BTKI, you can use Pirto, and it looks pretty good. But so ven-based versus Pirto, I go with ven-based for now until we have more data. Ven-based therapy, and the next class is obviously BTK inhibitor. We talked about how we think about the two. Here is relapse setting, so those studies are even more relevant. Once you're double refractory, so both classes are out.
And Mazyar, do we have any data with regards to survival if we initiated a patient on venetoclax-based regimen and then on relapsed refractory, you transition them to BTK inhibitors, or you started them on BTK inhibitors and then on relapsed refractory, you started on venetoclax-based regimen? Which approach is rather better?
We don't know that. There's the study that we may soon get some result of is CLL17 by the German group. That's Ibrutinib versus Ven-O versus Ibrutinib. In a way, your question of overall survival is like two arms of that study are kind of looking at that. I think you need a long follow-up for answering that question. I don't know if the first presentation, whenever we see it, would cover that. The difficulty is that treatments change so much that the type of subsequent therapies that patients got in that study may not be something that people have access to right now. To see an OS difference, especially in the frontline setting, is difficult unless you use chlorambucil in your control arm. It's a good problem for us.
Mazyar, once you've exhausted BTK and BCL2 inhibitors, our options are CAR-T and also Pirtobrutinib.
Then you have Pirto, you have CAR-T lysocell, and then you have PI3 kinase inhibitors. PI3 kinase inhibitors are not tested in this space, and they were part of the control arm of Bruin 321 study and didn't do well. So forget about PI3 kinase inhibitors unless we have absolutely no other option. They're also not super well tolerated. Between Pirto and lysocell, there's no competition. We need both. Pirto works really nicely and quickly, but limited duration of therapy.
Right.
Median is 19 to 20 something months, depending on what study you look at. So I start Pirtobrutinib. I'm pretty confident that it will work. I'm also pretty confident that it will not work forever. If I start Pirtobrutinib, I start also talking about CAR T cell therapy immediately. I hope one of the take-home points here in the relapse setting is that CAR T should not be the choice when Pirto doesn't work. It should be when Pirto is working.
Yes.
If I'm on service this month, it's very difficult to take care of CLL patients who are coming for CAR and their disease is explosive. And CLL could be nasty when it's in the relapse setting. So
Indeed.
once somebody needs Pirto, they need to start a discussion about CAR. That process takes months, so get started earlier. CAR-T can work 20 to 40% of the time, depending on which data you look at and whether or not you give it with a BTK inhibitor. Outcomes are better if your disease is better controlled. So, and safety profile is the same. That's my approach. Just start Pirto, think about CAR. If CAR works, great. Watch them off treatment. If CAR didn't work, you go back to Pirto and you think about clinical trials, of course, in all these lines, especially in the later.
Indeed. Well, in relapsed refractory settings, one cannot forget the importance of CAR-T approach here, and one should partner up with tertiary and quaternary centers here. Mazyar, thank you so much for taking the time to walk us through the current treatment landscape of CLL. For our listeners, let us go over a quick recap.
In this episode with Dr. Mazyar Shadman from Fred Hutch Cancer Center, we touch on the evolving CLL treatment landscape. The key is shared decision-making and balancing time-limited venetoclax-based regimens with continuous BTK inhibitors, where we do have long-term data, especially for high-risk patients.
Well, besides this, we also discussed choosing the right BTK inhibitor, role of MRD in guiding treatment duration, though this is not ready for prime time, and side effect management, and then sequencing strategies and options like Pirtobrutinib and CAR-T should be on our radar. Thank you for tuning in. We would greatly appreciate if you would take a few minutes to give us an honest feedback or leave us a review so that we can continue to bring these discussions to the bigger audience. See you soon in our next episode. We are the Oncology Brothers.